Hello guys, welcome to the Match Guy Biostats webinar. Today we will cover biostats, guys, and we will cover it through the Match Guy new step 1 QBank. Okay, and this lecture will be also good for those preparing for step 2 and step 3. Guys, the main idea of our QBank compared to other available QBanks in the market is, let's say, no, I will not mention names. I will not mention names. The other QBanks available in the market for step 1, the number of questions, they exceed 4,000 and they reach 4,500, which is very big, guys. They are great. They are great, but great for someone who has zero basics and have long time to prepare. You know, I saw many students telling me, okay, I can. My plan for step 1 preparation is 1 year. I'm preparing in 1 year. Okay, they have no problem in using a resource that has 7,000 questions. Okay. In addition, it is good for those big Q banks, good for those studying for medical school, studying generally for medicine to be great doctors. They are good. They are good Q banks. Okay. The common two Q banks in the market that you know. But our Q bank, the Machiga Q bank, is just 1,350 questions, which is condensed content. Condensed content focused only on step 1, passing step 1. The most asked concepts in step 1. This is it. So this is the first benefit I see in our Q bank compared to others. Focused, condensed for those who wanna get done with step 1 soon. Right? That is number 1. Number 2, another advantage with our Q bank compared to the others in the market, the choices, guys. When you do a question, for example, correct choice is A. Correct answer is A. Okay? Correct answer is A. Then you read the explanation, you will find the explanation very big. Okay? You read the other choices, you will find that the other related choices are only like choice B. Choice B is the only related one, while choice C and E and D, they are not much related. And this is another problem we cared for. Like, we designed our explanation to be not much long. Okay, you read the high yield things that you need to know. All right, we are here to make you pass the exam perfectly, not to make you a scientist, a specialist in GIT, gastroenterologist. No, we are not doing that. In addition, we designed the choices to be all high yield. All the choices are high yield. Okay, guys, that is a second important thing compared to Q banks in the market. All right, guys. A third advantage in our Q bank, soon, guys, we will be launching a daily live meeting discussing difficult questions in the Q bank. Right? We will go live every day. All our tutors will share in that. You will go live with us. Tell us what is your problem, what topic you want us to go through, what questions you are difficult for you. So this is a third advantage you can get from our QBank. Of course, I will not mention the advantages that already there in other QBanks, like making flashcards, making adding notes or adding colors or moods, etc., etc., etc. I'm focusing on the things that matters most for you. Okay, guys? All right. We are currently working on it, Speedy. We are currently working on it. All right. Let us go through the questions, guys. I will read the question loud, okay, guys, and you pick the answer. Guys, how to, before generally for your USMLE prep, before going through any chapter, you need to put the goals, or to be more specific, what should I master in this chapter as topics and as approach, okay? For example, when you're studying for musculoskeletal, I will tell you, in musculoskeletal, all the assessments that I saw, without mentioning the names, you already know what I mean. All the assessments I saw, okay, asked about the nerves and the muscles. One question per nerve. one question for musculocutinous nerve, one question for radial, one question for axillary. Okay. Okay. They also ask about gout mostly. Each assessment has at least one question about either rheumatoid or osteoarthritis. So for musculoskeletal, I know what topics are mostly asked. Also, the approach, how to study a chapter like that for musculoskeletal, muscles and nerves, easy, direct. You need just pictures to help you memorize. Okay. Diseases, the pathology, it is just about diagnosis. It is just about risk factors. They love the risk factors and they love the farm. Okay. For biostats, guys, for biostats, all assessments, step 1, step 2, step 3, will have one of those questions, one of those categories. Number 1, a question from study design. Number 2, a question from statistical tests. Number 3, a question from normal distribution curve. Number 4, a question from bias and study errors. Number 5 and number 6, 1 or 2 equation questions. For step 2 and step 3, 1 or 2 abstract questions. Okay, guys? So before going through biostats, those are the topics you need to master. Those are the topics that will cover 70 to 80% content of any exam that you will see in your life. So I need to give my attention to those first before covering too many questions here and there, jumping from this QBank to this QBank to that QBank to do as much questions I can. No, I will master the basics first, then I will jump into the others. Okay, guys? Let's see. This question covers the first topic I told you about. And while doing that question, each topic I will tell you how to study it for the USMLE. Okay, let's see. We start by reading the last line of the question. Which of the following best describes the method of data analysis? Okay, and guys, after you read the last line of the question, you skim rapidly to choices to see what is this topic. What is the topic of the question? Intention to treat analysis, as treated analysis, crossover trial design, per protocol analysis, stratified randomization. So I guess this is something related to study design and how to analyze the results you got from the study you made, right, guys? This is what comes to my mind. Okay? All right. So now, since my mind is in a certain topic, types of studies, and analysis, okay, then the specific keys of each one are in my mind. Okay, let's see, guys. A randomized control trial enrolls 1,500 patients with newly diagnosed hyperlipidemia to compare a novel lipid-lowering medication with a standard statin therapy. Okay, new drug for lipid against the statin, the standard one. Participants are randomly assigned to 1:1 ratio to receive either the new lipid drug or the standard statin. The primary outcome is the incidence of myocardial infarction over 5 years. During the study, 25% of the participants assigned to group A discontinued the medication due to muscle pain and taking standard therapy. Additionally, 15% assigned to group B obtained the novel medication outside the study protocol. What is that, guy? Some people from this group took this drug, and some people from group B took the drug of group A. All right? This is outside the study design. At the conclusion of the trial, investigators analyze outcomes based on the treatment of each participant was actually taking. The patient was actually taking, okay, at time of follow-up, regardless of their original randomization group. Which of the following best characterizes this method of data analysis? What is this, guys? It is not A. No, 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 no. It is not D. It is not C. Now it is B. B, not B also. C, it is C. Sorry, guys. I told you it is not C. It is C. C, guys. Sorry. It is C. Okay? What about it here, guys? What about it? What about C? Guys, look. I designed the study. I have two groups. This is group A, and this is group B. All right, guys? For prospective studies, guys, like clinical trials or prospective cohort, there is a common problem called attrition bias. Right, guys? What is attrition bias? Since the study lasts for long, guys, in the future, like I'm doing a study for 5 years. People died, people left the study because they traveled abroad. They are no longer interested in your study. Okay, they changed their contact details. So you lose some patients. You lose. So let's say in group A, you lost 20% of the participants, and in group B, you lost 25 of the participants. Okay, guys? So now, guys, how to deal with this problem? We reached to the end of the study here, 5 years. We collected the results of 5 years, and we want to run our analysis. How to deal with this those who last follow-up? Scientists, guys, differed here. The first team of scientists, the data scientists, the data analysts, said, I will include everyone in my analysis, include all. I will include all. They call this approach intention to treat analysis. Intention to treat analysis. Okay, guys? I will include everyone in my study, those who completed and those who lost. Why? Why are you doing that? They did not complete your study because we are concerned for randomization. You get me, guys? This is their goal. They want to preserve randomization. What does this mean, guys? When I designed the groups in the first place, guys, when I designed the groups, okay, they were randomized according to the confounders, the baseline characteristics, etc., okay, to control confounders. Now, when people no longer participate in the trial, when we lose some people, that affects the randomization process. So the goal here is to preserve randomization that is high yield, and I saw it in some other questions. Okay, that is intention to treat analysis. I will include all. All right, guys. All right. Number two. And since, guys, another important point I saw it asked before, since you preserve randomization, that increases the internal validity of the study. The study does not have bias now, so high internal validity, strength of the study. Also, this design has high external validity. What does this mean? External validity, guys, means your results are representative of the society. Your sample representative of the society. In general society, guys, in general population, do you all guys take your medications? I have 78 in the meeting now. Do you all take your medication course till the end and you are consistent with the drug 100%? Of course, no. Of course, no. So losing some people in the trial, that is healthy. That represents the society. High external validity. Okay, guys? So this is what the first team of scientists said. The second team said no. No. I do not matter about, I do not care about those who left my study. I will include only who completed the study. Only those who completed the study, and they called their approach pair protocol. Okay? Pair protocol approach. Pair protocol approach. Okay, guys? Unfortunately, pair protocol approach has low external validity. Low external validity. All right, guys? It does not represent the society. It is perfect scenario. It is a perfect scenario. Clear? Okay, so we covered two of the choices. The third point, the main point of our question, what is as-treated analysis? As-treated analysis, guys, as I told you, I have group A and I have group B. What happened is some of participants in this group went here and took drug B. They went here and they took drug B. All right. And some of participants in group B went here and took drug A. I did not tell them to do that. They did this themselves. They went and did this themselves. Okay, guys? And they are asking you here, what to do with those people? What to do with those people? Those people who came from group A, and they took group the drug B, I will include them here. While those, I will include them here. This approach is called as treated analysis. I will analyze the results according to the actual drug they used. Actual drug use. I belong to group A, guys. I belong to group A. But I left my group and I went to the second group and took their drug. So what will you do with me? Put me in the drug category that I took. Simple like that. That is called as treated analysis. As treated analysis. Okay, guys? As treated analysis. All right. As treated analysis has a huge problem, guys. You tell me in the chat what problem it is. No, 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 no. Yes, what bias? I just told you about it, guys, minutes ago. Unfortunately, that will damage randomization. That will damage randomization, guys. Because once I started the study, it was perfectly randomized. Now, some people on their own took a decision to go from this group to the other, and people from here took a decision from their own mind to go to the other group. That disrupted my randomization process. Okay, guys? So the biggest problem here is randomization. Okay, guys? Okay. Huh. The another choice was talking about crossover trial design. What is crossover design, guys? Crossover design, when I make my two groups take both the placebo or the standard and the due drug. How is that? This is the group A. Okay, guys? This is group A. They will start by taking drug A. And this is group B. They will take drug B. All right, guys? Then I will shift them. This group will take B, and this group will take A. So each group, guys, took the drug A once and the drug B once, with a period in the middle called washout period. This design is called crossover design. Why? Why am I doing that? Because if me, the same person, took the drug once and the placebo once, I'm controlled, guys. I'm the same guy without the same hidden variables, the same possible hidden confounders. I'm the same guy. Okay, guys? All right. So this is controlled design. That is crossover design. And the difference between crossover design and astrated analysis, crossover design, I made it myself. I'm the observer of the study. I made it myself. I give you the drug A once, then drug B. Me, I did that. While in astrated analysis, people left the study on their own. They went from this to this on their own. Okay, guys? Since the answer to your question, Yemen, Um, the answer to your question, you damaged the randomization. So randomization affects the study itself, so lower internal validity. Okay, guys. Washout period in the middle. Yes, John. Yes. Okay. Exactly, Carol. Yes, exactly. Okay, guys. Okay. So you see, guys, as I told you, all the choices are high yield. All the choices are high yield. This is why we made the QBank. You will not see that in the classic QBanks in the market. So if I'm a student, I will study like this. If I'm a student, I will study like this, guys. Okay? I read the question. I have a very good picture here that compares intention to treat analysis with per protocol, with as treated population. I read the explanation. I have a good table here. Okay, all other choices are high yield. I will study that all the choices, and there is a good picture here for crossover design. Okay, all right. I have a good table here also, and I have a bottom line. Okay, guys. Okay, next question two. I will read and you answer. As I told you always, we read the last line of the question and skim rapidly through choices to know what topic it is. Which of the following best describes the clinical trial phase represented by this new study? Clinical trial phase 1, 2, 3, 4. Okay, so phases of clinical trial. Okay, very well. So it comes to my mind the phases of the clinical trial and the specific key, the specific secret to which phase. That comes to my mind. So when I read the question, my eyes are expecting the specific keys. Okay. A research group is designing a clinical trial for a novel glucagon-like peptide analog intended for the management of type 2 diabetes mellitus. Previous data collected from animal models indicated high receptor affinity and favorable toxicity profile. Subsequently, after it succeeded with animals, subsequently a trial involving 45 healthy volunteers, was conducted, which established the drug safety and tolerability and pharmacokinetic parameters. Okay, so the second phase succeeded. The researchers are now preparing to enroll 120 participants diagnosed with type 2 diabetes. Oh, I have diseased patients to enroll in the study. This new study aims to assess the drug efficacy in reducing hemoglobin A1C levels compared to placebo, monitor for adverse effects in the target population, and identify the optimal dose range. Which of the following best describes the clinical trial phase represented by this new study? Hmm. I see half of you choosing phase 2 and the other half choosing phase 3. Hmm. Which one, guys? Let's go with choice B, right? Okay, what is this, guys? Phases of clinical trials, high yield. Let us talk about phases of clinical trials. Okay. Clinical trials, guys. I'm working in the lab now. I'm working in the lab. I had an idea. I tried it over lab animals, the rats, the mice, the pigs. This is phase 0 clinical trial. In the lab, who of you guys heard recently about a study in Asia about a transplanted kidney that worked in pigs? You know, a new kidney device machine that worked in pigs. And this machine will replace the kidney induced with renal failure, chronic kidney disease, and we no longer will need hemodialysis. It will be really great. Okay, that is phase 0. It was published recently, guys, months ago. All right. So I test my idea in the lab over lab animals. If it worked, guys, then I will go to the second phase, phase 1. It worked in animals, so let us try it over humans. Okay. Which humans? Thank you, guys. Healthy humans, healthy volunteers. Healthy volunteers. Why healthy, guys? I do not know if my drug will be safe in humans or not. So I want people with healthy body, healthy systems, okay? Healthy kidney, healthy liver, healthy metabolism, healthy immunity to tolerate the drug in case it has adverse effect. So the main concern in phase one is the safety of the drug. Of course, I can assess other things along with safety, like the drug dose, the route of administration, and some of efficacy. But no, the main concern is safety. The drug is safe or not. If the drug proved that it is safe and has some of efficacy, then I will go to phase two. Now I will try it over diseased patients, but small number of diseased patients. Small, not all diseased, not all diseased. Small number of diseased. Okay, guys? Small number of diseased. All right. Okay. So small number of diseased patients. Here I will assess multiple things. I can assess some efficacy and also safety in disease, and also drug routes of administration, the dose, etc., etc. If it succeeded, I will go to the main event, phase 3. Sorry. I will go to the main event, phase 3, large number of diseased patients. This is the main event, guys. This is the event for drug approval by the FDA. So I'm designing a control design. I have treatment group, and I have control group. Okay, double blinded, randomized. I'm trying to control the bias. Okay, the large number of participants, thousands, because this is the one for the drug approval. Once the drug succeeds here, guys, it will go to the market. Once the drug in the market, guys, then we will go to phase 4. Once the drug in the market, we will go to phase 4. Okay, guys? All right. We will go to phase 4. Okay. Phase 4 is called post-marketing survey. The drug is already in the market, guys, and patients are taking it. It is prescribed for patients, right? Here we address long-term adverse effects of the drug. Long-term adverse effects of the drug. Okay, guys? Here we assess long-term adverse effects of the drug in case the drug has rare adverse effects, has certain teratogenicity, etc., etc. Okay, guys? All right, that is phase 4. If the drug proved that be really teratogenic or shows serious adverse effect, it can be taken away from the market. All right, guys? All right. Those are the phases of clinical trial. How USMLE ask about clinical trial phases, guys? I will describe the phase, and I ask you what phase is this. So, for example, I might describe enrolling healthy volunteers. What phase is that? Phase 1. Okay? Or ask you about the purpose of each phase. Phase 1, clearly, healthy volunteers assesses safety. What is safety? Okay, guys? All right. Okay. Let's get back. Next question. A 38-year-old man comes to the neurology clinic because of 4 months history of progressive. Oh, wait, I forgot to read the last line of the question. Okay, which of the following best describe the study design? Case control, cross-sectional. Oh, this is a study design question. Study design, then it comes to my mind the specific key to each design. And then when I read the question stem, my eyes will be automatically taken to the design. Okay, a 38-year-old man comes to the neurology clinic because of 4-month history of progressive weakness in hands and feet. Okay, and intermittent double vision. Okay. Physical examination shows bilateral ptosis, mild weakness in the wrist extensors, and ankle flexors, dorsiflexors. Over the following year, 5 additional patients are identified at the same tertiary care center with a nearly identical constellation of symptoms. I have some other people, 5 other patients with the same symptoms. All 6 patients undergo a standardized diagnostic workup, including electromyography, muscle biopsy, specialized autoantibody panels. The treating neurologist tracks the clinical presentation, laboratory findings, and response to immunotherapy for each patient over 18 months period. The findings are compiled into a report to characterize the clinical phenotype and natural history of suspected new autoimmune disorder. Which of the following best describes this study design? I see 6 patients with the same symptoms, triggered by a recent drug, a recent vaccine they took. So I reported and published these interesting results. This is simply the question. What is it, guys? I see you all agree on case series, right? Let's see. Very good. Okay. As I told you before, guys, look, all the choices are high yield. There is a comparison table here. There is a picture for those who love pictures. Okay, let me tell you what do you need to know in study designs asked in USMLE step 1, 2, 3 assessments and QBanks. Super high yield. Okay. So again, guys, for those who did not attend the session from the start, now, if my exam in 1 week and I know nothing in biostats, my exam in 1 month, I know nothing in biostats, and I just want to cover at least 50 or 60% of the biostats, and since step 1 pass or fail, I'm happy. I'm happy with those 50, 60 biostats percent. Then go through study designs and clinical trials, errors, bias, normal distribution curve, statistical tests, 1 or 2 equations of the things that I will tell you about later. Okay, guys? Easy, simple like that. USMLE, guys, USMLE is not complicated. USMLE is not impossible. Medicine generally is not complicated and is not difficult. Medicine, guys, is classified as middle IQ. Middle. Engineering, chemistry, mathematics, they require high IQ, while medicine is classified as middle IQ. It just requires memorization. Is it difficult, guys, if I come here and tell you phase 0 done over lab animals? If succeeded, I will try the drug over healthy volunteers. What is difficult here, guys? What is difficult? Is that difficult to understand? No, it is easy to understand. It just needs some memorization and doing some questions. So tell this to yourself, guys. It is easy. You can do it. You can just have clear plan, good mentor, good guidance, and you can do, and some effort from you, and it will be done. It is easy, guys. Okay? So here, study designs. Let me tell you about all the study designs you want, starting with number 1. And I saw a study published 4 or 5 months ago, guys, about a patient. They reported a very interesting patient. A patient who, 1 second. Okay. Thank you, Barry. Thank you. Okay. I read a study. It was an abstract, published abstract, about a patient who recovered from rabies. Can you imagine that, guys? Who of you guys went through microbiology, through rabies? Once rabies symptoms start to appear over the patient, hypersalivation, altered mental status, sensitivity against water, spasms, the patient definitely will die. But they reported a patient, a very interesting patient who recovered from rabies. It was an abstract like this, introduction, methods, okay, how they collected the results, how their conclusion, their comments, like this. What study design is this? Case report. Okay, guys? Case report. So case report, you saw an interesting case who recovered like this, rabies. You see interesting rare adverse effect to a drug. For example, a patient prescribed acetaminophen developed cyanosis in whatever, cyanosis or anaphylaxis, whatever. Oh, it is not known, no link between acetaminophen and cyanosis. Oh, it is really interesting. Let's publish this case. So case report. Okay, guys, easy, and everyone is reporting that the volume is okay. Make this. Maybe you can try to raise your device volume. Thank you. So this is the first case. Okay, guys. What if you have multiple patients? Multiple patients how? Guys, two years ago in my clinic, okay, I saw people who took corona vaccine, who you took COVID vaccine, guys. I noticed that nine of my patients who took corona COVID vaccine and they have diabetes mellitus, COVID plus diabetes mellitus, they developed renal failure. That is not true, guys. This is just my example, an example that I made. Okay, and I'm not mentioning any names of the vaccines. Okay, so 9 of my diabetes patients who took one of the COVID vaccines, they developed renal failure. So I published those interesting results as an abstract like this with table showing the results and the data of my patients. What is this? Case series. So one case report, multiple cases, case series. Okay, guys? All right. What is the third study design? The third study design, guys. The clinical trial. Right, guys? The clinical trial with its 5 phases. We already talked about it, right? So let's go to the next. The fourth study design, guys. Cross-sectional. What about cross-sectional study? You know, guys, who of you guys who attended the course, that the match guy high-yield crash course and attended the biostat session with me, I tell them this. You read the last line of the question. Oh, what study design is this? And you see the choices showing different types of studies. Then you go to the question stems and your eyes are looking for the keys. Once you see this key, we were running a survey. We were running a questionnaire. Then close your eyes and pick cross-sectional study. Because this is the most common study design in questionnaires. How is that, guys? Guys, I wanna study the link between studying USMLE Step 1 and the depression and fast food consumption and obesity. Okay, so I will, in 1 minute, I will create a survey, online survey with Google survey, and I will send it to the group now. Here I have 80 person in the meeting, 80 in the meeting. Okay, guys, I will send you the link. If you all fill the link, guys, okay, in 1 minute, I ran a study. That's why cross-sectional study is used in surveys. In 1 minute. It is cheap. It costs me nothing. And it is the best study design assessing prevalence. Super high yield, guys. Ask it. This study is best for what? Assessing prevalence. Now, 80, you all guys filled the questionnaire, all right? I now can easily know the rate of depression, the prevalence of depression in this group. Okay, guys? But it has one problem, guys. Since it assesses risk factors plus outcomes at the same time, this is not good. This is not strong. I'm assessing everything at the same time, guys. I'm assessing how you study for medicine and your effort, your grades, your exams, and the rate of depression or the rate of obesity I'm talking about. So you assess the risk factor and the result at the same time. So this is not a strong relationship. Okay? And that is asked before, guys. You assess the risk factors and outcomes at the same time. I saw examples like this. I'm assessing smoking and COPD status at the same time. That is cross-sectional study. Okay, guys? All right. The next design. Cohort, prospective cohort. Prospective cohort study. What about it, guys? What about prospective cohort? Prospective cohort, I have two groups, guys. With a group with a risk factor, a group without a risk factor. A group with risk factors like what? Smokers group and non-smokers. Okay? Then I will follow the groups, guys, for 5 years to see who of them would develop COPD. Who of them would develop COPD? That is prospective cohort, guys. That is prospective cohort. So you need to know the design. And there is a common trick here for the steps, guys. A super common trick. This trick, guys, is once you see the word COPD, it comes to your mind, COPD, then COPD must be the outcome. I will put COPD as the outcome. And that is wrong. That is wrong. COPD can be an outcome in a certain design like this, and could be a risk factor in another design. How's that, guys? In another example, I can tell you, I want to study how if COPD can lead in the future to pulmonary hypertension. So here the groups will be COPD and the non-COPD, and the outcome would be who developed pulmonary hypertension. Pulmonary hypertension itself can be a risk factor, not an outcome. In another example, I can tell you I will study those with pulmonary hypertension, those without pulmonary hypertension. I see in the future who would develop right heart failure. Can you imagine? Right heart failure can be a risk factor for another outcome. Why is this important? Because USMLE ask a very common question here. They ask you what should be our control group. They tell you, I'm designing a study using the prospective cohort design. I will follow prospective cohort design. What should be my control group? Help me design the group. Okay, guys? So do not look at COPD, for example, and tell yourself COPD is in the result. No, it might be a risk factor. Do not see pulmonary hypertension and say it is an end outcome. No, it might be a start point. Okay, guys? So read the question carefully and look what their purpose is. So this is prospective cohort. You start with the risk factor and you wait for the outcome for years. And so since you wait for years, guys, many people will lose follow-up. Lots of follow-up bias, guys. Lots of follow-up bias. People die. People change their contact details. People are no longer interested. People immigrated, traveled abroad. Okay? Okay. So, and we talked in the first question how to fix loss of follow-up bias, right, guys? We talked about how to fix the bias. Okay. All right. What else? Since this is a future study, guys, this is a future study, right? It can assess incidence. What is incidence, guys? We will cover it later. New cases. New cases. Remember, guys, and compare. Cross-sectional, it is the best for assessing prevalence, while here, prospective cohort, new cases. New cases, okay, guys? It is the best for assessing new cases. Okay. That is prospective cohort. All right. Next design. Retrospective cohort. What about retrospective cohort? It is a cohort study since you start with risk factor and you end with outcome. Okay, the study has this design. You start by risk factor and end with outcome, but it's called retro because both the start point and the end point was in the past. For example, I will go to my hospital. I will go to the department responsible for the records. I'm asking the department, bring me the files of patients starting from 2012 till 2018. I will start at 2012. I will take the files of people with obesity, for example, okay? And will track them back in time till 2018 to see how many of those obese patients developed diabetes mellitus, for example. Okay, so I started with the risk factor obesity and ended with the outcome diabetes, but the start and the end point were in the past. That is retrospective cohort. Okay, Then this is retrospective cohort. Okay, guys? So whenever you read the last line in the question stem and the choices, and you understand that this is a study design, then what to do? When you read the question stem and you see this medical records, medical files from a past year, close your eyes and pick retrospective cohort. Okay, guys? And pick retrospective cohort. The answer to your question, Angie, in retrospective cohort, you start with the risk factor and end with the outcome. Okay? So here in my example, obesity is the start point, diabetes mellitus was the end outcome. The next design, case control, very common. Case control. The name tells you guys, case control, case control. So I will study with cases against controls. And then I ask them about their history, their past history. Okay? How is that, guys? I will go to patients with pancreatic cancer. I will go to my hospital now. Okay? I will go to those with pancreatic cancer department. Okay? Then I will go to them and ask them about their past history. Their past history. Who of you guys, for example, tell me about your smoking history, about alcohol history, about diet, about occupation, about your job, about your lifestyle. Okay? So you're asking people about their past. Someone might ask me, why am I doing that? Design a prospective cohort, for example. Bring a control group and a group with a risk factor and study it. I will tell you, no. Case control, I need it in some certain situation. It is the best in certain situation. Number one, if the disease is rare. If the disease is rare, okay? If the disease is rare, then the best study design is case control. How is that, guys? Imagine, guys, I'm living in a city that has 40,000, okay? In my city, I have, let's say 10 patients with albinism. Okay? So that means it is rare. It is relatively rare. All right. So and I want to study the risk factors that might be associated with developing albinism. So what is the best design? I can simply go to those 10 patients. I will go to their home, okay? And I will ask them about their past history. And I will bring a group of control with the same baseline characteristics and ask them about their history. And now my study is done. Rapid, cheap, effective. It is bit I cannot perform a cohort here on 40,000 patients. Imagine doing a cohort study over 40,000 participants. So at the end, you get 10 patients with the disease. That is super expensive and not practical. So the best study design for rare diseases is case control study. Okay, guys? Case control study. All right. Also, guys, that is a point I saw in questions before. If I do not know the risk factors, imagine, guys, a new disease. A new disease called what, guys? We want to have a name for a new disease that is not there. Let's call it disease X. Disease X, okay? We have disease X appeared in the society, guys. And we do not know what are the risk factors that led to the disease. Then which study design to start with? Case control. Simply case control. All right? I will go to people who got disease X. Please tell us about your history. We know nothing about the new disease. Tell us everything in your life. We want to generate hypotheses. Then those patients will tell you, you will take history from all the patients and you will find the things in common. For example, in common, I saw all of them are smokers, all of them are alcoholics, okay, and all of them are obese. So those are the common risk factors between the people. Then I will study those risk factors more and more with more study designs. That's why I can tell you that case control study helps me generate hypotheses. Helps me generate hypotheses. And that is a question that I saw asked before. Okay, guys? All right. The bias. The bias. What is the bias related to this study? You come to me, guys, and ask me, what is your history? What is your history? I do not remember, of course. I forgot. I forgot what was my breakfast this morning. Okay. So of course I will not remember 100%. The memory is biased. Recall bias. Memory is biased, guys. If you pass the step one, okay, you you will, and I ask you about your preparation, you will tell me, oh, it was great. It was effective. I studied the question for one time and it stays in my mind. While if you did not pass or you spent long time, you will tell me it was a bad preparation. Step one is bad. All right. So your memory is biased. Anyway, so the bias here is recall bias, guys. How to fix recall bias? Simply do not depend on memory. Depend on records. Depend on records. Okay? How to depend on records? Simply, guys, do not come to me and ask me about the drugs that I took last year. Okay. You can go to my medical record. I give you the permission. You go to my medical record and look at the drug doses and the drug types that I took last year. Simple like that. Okay, guys? Okay. All right. So, guys, what you need to know here. This is how you study USMLE effectively. You understand the concept, you know how they ask about the concept in the exam, and this is what we give you here at the Match Guy, guys. Guys, how to gain this skill? I'm telling you the ways they ask about the question, the different ways they ask about study designs, for example. For example, in here I will tell you, they describe a design and ask you what design is this, or they will tell you design the control group. Imagine we are performing case control. What is that? The control, what should be our group? What should be our design? You design it for us. What is the bias related to it? And sometimes how to fix the bias, like loss of follow-up bias. And what is the importance? For example, prevalence with the cross-sectional, for example. Okay? Case control helps us generate hypotheses. So those are the 5 different aspects they might ask you about. So how to gain this skill, guys? The skill of knowing all aspects of questions to be asked. Number one, doing as many questions as you can to gain the skill. I did thousands and thousands and thousands of questions since I have been tutoring for 4 years till now. Okay, so I did thousands of questions and I got the skill, but that consumes time. That's number one. Number two, the second way, you work with a mentor, someone to guide you. For example, here at the Match Guide, we can guide you, all right, through all chapters. We can do questions with you. We can follow your progress. We can draw you the plan that fits you. Plan for 1 month. You're ready for the exam. You're not ready. You need another month. Okay? And save your time, save your effort, especially for those who are old graduate, those who have narrow time and they are studying for the school, they are working. Okay. Number three, but less reliable, actually, ChatGPT. ChatGPT sometimes can help you, can tell you how USMLE asks about it, the specific keys about each disease or each drug, but actually it is less reliable than doing questions and having a mentor. Okay, guys. All right. Okay. So here, guys, a summary. Till now, we covered 3 or 4 of the topics that come in the exam. The real deal, Wally. I'm talking about the real deal, but just an advice in the middle. Okay, so 3 or 4 of the topics that I told you come in each of the assessments, guys. We talked about different study designs, and I told you all aspects of questions that are related to the designs. Okay. We talked about the observational studies, the clinical trials. We talked about analysis of results, how to analyze the results in case you lost some follow-up. Okay? All right, guys, let's get back. And the next question. As I told you guys, of course, no, Angie. They will not give you the formula. Now the question becomes easy. You must memorize the formulas, Angie. You must memorize the formulas. Okay. Which of the following best explains the difference between the crude and the stratified relative risk? Crude risk, stratified risk. Confounding, effect modification, information bias. So, bias question. Okay, then my brain now is arranged, guys. My brain knows the specific one or two keys with each bias types. And while reading the question stem, my brain will stop me here. That is the key and go to the answer. Okay, that is how my mind works, guys. So let's see. Okay, all right. So investigators conduct a prospective cohort study to evaluate the association between between a newly developed medication for chronic migraine and the long-term risk of ischemic stroke. Okay, a total 8,000 adults, okay, with a history of chronic migraine enrolled and were followed up for 8 years. Initial analysis of the data reveals crude relative risk of two for ischemic stroke among medication users compared to the non-users. However, investigators observed that the patients prescribed the new medication are significantly more likely to have a pre-existing hypertension than those not taking the medication. To address this, researchers perform a stratified analysis based on the presence or absence of hypertension. In the stratum of patients with hypertension, the relative risk of a stroke is 1. In the stratum patients without hypertension, again, the relative risk is still 1. Which of the following best explains the difference between the crude and the stratified relative risks? Initial analysis showed that my drug works. Relative risk equals 2, which is significant. But after stratified analysis, which means detailed analysis, controlling or hidden variables, the relative risk equals 1, which is useless. So what is that? I see all of you choosing A, right? Confounding? Let's see. Very good. Yes, confound. Okay, guys. What is this, guys? What is this? I will make you understand the concept as we always do, guys. I will make you understand the concept, then I will tell you how USMLE asks about the concept. What is confounding? Imagine, guys, I came to you now and I told you I ran a study. Myself, I ran a study, all right? My study showed that coffee drinking is associated with lung cancer, right? Coffee drinking is associated with lung cancer. You will come to me, how is that? Coffee goes to the GIT. What is the relation between coffee and lung cancer? If I tell you GIT cancer, it might be easy to believe, but lung cancer, how is that? There must be a hidden variable affecting your study, for example, smoke. Did you assess your participants according to smoking status? Because it might be a hidden variable in smoking that causes the lung cancer. That is confounding, guys. Okay? All right. This is just for your understanding. There is hidden variable that creates a false relationship between the exposure, coffee drinking, and the outcome lung cancer. False relationship. Okay. Now how USMLE ask about it? USMLE ask about it like this, guys. We ran crude analysis. Crude analysis, guys, simply is initial analysis. Initial rapid analysis we did without putting into consideration the hidden variables. So initial rapid analysis I did showed that coffee drinking is associated with lung cancer. Okay, that is just the crude or initial. All right. Okay. Now adjusted analysis, and this is the answer to your question, Carol. Adjusted analysis or stratified analysis, that is detailed one, that is accurate one, that one puts into consideration the possible confounders that might affect my study. How is that, guys? How is that? Oh, you tell me coffee is associated with lung cancer. I think there might be a hidden variable here. Might be smoking. So I will analyze the results and I will classify people into smokers and non-smokers. And now I see what the relative risk will become. You told me in your crude analysis that relative risk equals 2, which is significant. In my stratified analysis, the significance will disappear. So in the smoker group, I find that relative risk is 1. Non-smoker group relative risk is 1, which means useless. Okay, guys? So coffee is not associated with increased lung cancer. That is confound. This is the first way USMLE questions ask about confounding. The second way, so I saw that question multiple times. They in the question stem, they describe this, guys. They describe this. People or participants are adjusted for etc are adjusted. People are matched. People are randomized. People are matched, are randomized, adjusted, and they ask you, this study design helps prevent what? Prevent confounding error. Help prevents confounding. Okay, guys? All right. So you see words like that, they ask you, this study design protects from what? Protects from confounding. Okay, guys? That is the second question I saw you simply asks here. Okay, guys? The third question, the point that always come in differential diagnosis with confound, which is effect modification. What is effect modification? What is effect modification? Effect modification, guys, something that enhances the relationship, enhances or decreases the relationship that is already there between exposure and the outcome. How is that? My drug X, I found that it really decreases stroke risk by 30%. 30% decrease in stroke risk. All right? My drug actually works. It decreases stroke risk by 30%. I found an interesting thing that in smokers specifically, it protects them also from stroke. Yes, it decreases the stroke risk, but by 50%, higher than general population. Okay? Higher than general population. Then what is that? That is effect modification. That is modifier, guys. There is a true relationship between my drug, the exposure, and the outcome. There is a true relationship. And I'm coming to you to either enhance or decrease the relationship. That is effect modifier. Unlike confounding, guys, it is creating false relationship between exposure and the outcome. False relationship between exposure and the outcome. Okay, guys? That is the difference. And that is the answer to the question, Husseini. Okay, guys? All right. We exceeded the hour, guys, so I will stop here. Please tell me if you have any questions before ending the meeting. If you want help, guys, if you want guidance, text us. We will help you. If you want us making you a plan till your exam, a schedule till your exam, mentoring, one-on-one tutoring, you want to go with me or with my other tutors through the questions, okay? Do biostatistics questions with you, biochemistry questions, text us and we will do that for you. And also, guys, we have a condensed crash course covered in 1 week for USMLE Step 1 and 2 and 3. 1 week condensed course that covers all the high yield materials in the way I'm doing here for you, explaining the concept, telling you how USMLE ask about the cut, and giving you all the notes. Okay, guys? The courses, me, Sai, and all other tutors who got nearly above 70. Okay, experienced tutors, top notch. In 1 week, guys, 9 hours per day. 9 hours live, guys. So that, you know, guys, we have been doing the course, the crash course for 20 times till now. All right, for 20 times, and there is a one starting for Step 1 next Monday. It is live, guys, to help people with consistency. All right, you have WhatsApp group to share your ideas. All right, and if you have any problems, we can here help you. If you have any question, we answer you. The sessions are recorded, so any day you miss, you have the recorded sessions, you have the Anki cards, you have the high yield files. Okay, guys. And also the QBank, guys, as I told you before, it is short, condensed QBank, has all the high yield points. You can finish it in 1 month and master it. It covers like at least 70 to 80% of the high yield content required to pass Step 1 easily. Okay, guys. There is a step 3 crash course. Medik is actually running now, and I will be doing the ethics session in 3 hours. All right. And we will be conducting another one for step 2 and step 3 soon. You can contact the support team and they will guide you. Yes, on ICA there is all the sessions are recorded. And also you can get the recording of the prior crash courses. So you have each substance recorded by multiple tutors to see which one best fits you. No, IUG, the WhatsApp group are for those who participates. Each cohort, each crash course cohort has their own WhatsApp group. You can text the support team guys. They will give you the exact details of the upcoming crash courses. All right. We are now holding a crash course every week, like 4 times per month. Okay, guys. All right. It was nice meeting you guys. And please follow us for more content. We will be doing high yield sessions. All right. High yield sessions every week, talking about the topics you asked. You asked for biostats. I came here for you. Also, soon we will start for our QBank. Do subscribing on our QBank every day, 1 hour. Can you imagine that? 1 hour live every day. You go with the tutor through the questions you want. I have difficulty with study bias questions. I have difficulty with that question. I have difficulty with this, and the tutor explains everything for you. All right, guys. All right, that was a really great session, and I will meet you soon. This is not the last time. Definitely, I will see you soon. Okay, guys. I wish you all the best in your preparation.